That is how D1 receptors work in the kidneys and heart and blood vessels, causing vasodilatation. At moderate doses, it acts on the beta 1 adrenergic receptors, increasing heart rate and contractility. At high doses, it acts on alpha 1 adrenergic receptors, causing the vasoconstriction. So the D1-like receptor activation stimulates adenylyl cyclase and increases cyclic AMP production, leading to PKA activation and then downstream effects. So I don't know if you guys ever noticed this recurring theme that most of these receptors activates or stimulates adenylyl cyclase, which then forms cyclic AMP, which then leads to PKA, which then causes the effect. So if you took anything from today's episode, I would write this down because it seems it's the same pathway for cause and effect in almost all of these drugs, which is, again, when you activate that receptor, it stimulates or activates adenylyl cyclase, which then increases cyclic AMP production, leading to PKA activation and then downstream effects. Well, hello, everyone. Welcome back to CRNA School Prep Academy podcast. I'm your host, Jenny Finnell, CRNA, and today is going to be part 2 of the G protein coupled receptor pathways. But today we're going to do something a little bit different in that we're going to go into the protein kinase A and kind of its involvement. There's going to be some overlap, but my hope is that by the time you're done with this part 2 series, that you're going to have a better understanding of how critical care drugs such as epinephrine, norepinephrine, and things like that work down to the molecular level. These are very common interview questions that are asked in the CRNA interview. So my hope is that you take notes. Just like the last time, we will have a resource for you to download. If you go down in the show notes below, you can go ahead and get that downloaded now. Might save your hand from cramping from taking so many notes because I will be going fast through this. It is going to be heavy, so just a fair warning. But again, I hope you guys enjoy, and let's go ahead and get into the show. Okay, so as I said, we're going to go into the protein kinase A. I want to explain that in a little bit more detail since we went into the G proteins last time. I know we touched on the PKA and its involvement, but we're going to go into a little bit more detail, and we're also going to go into more of a deep dive into different medications and their mechanism of action. Again, in the study notes below, we're going to have all these medications and the mechanism of action listed out for you. We're also going to have some additional medications listed out for you that are not necessarily involved in these pathways, but I feel like they're important medications for you to know. So I went ahead and included them. But just for this episode, we're not going to discuss those medications. We're only going to discuss the medications that cover the G protein and the PKA pathways. All right, so protein kinase A, or PKA, it's a key enzyme in the cyclic adenosine monophosphate, or also known as CAMP or CAMP signaling pathway. It's involved in multiple cellular processes, including the heart, where it regulates contractility, heart rate, and other functions. PKA acts through a signaling cascade that starts with activation of a G protein coupled receptor, GPCR, also abbreviated as, on the cell surface by a vasoactive or cardiac drug. So we're going to look at, like, for example, let's just talk about beta adrenergic receptor for an example. So receptor activation, a drug like a beta adrenergic agonist, like isoproterenol, for example, binds to the beta adrenergic receptor, which is a type of G protein coupled receptor on a cardiac monocyte, so a cardiac cell. Then you have the cyclic AMP or the cyclic adenosine monophosphate, also stands for that. Once activated, the G protein coupled receptor then stimulates a G protein, which in turn activates adenylcycline or adenyl cyclase catalase to convert into ATP, convert ATP into cyclic AMP. So let me say that again, because I got a little tongue tied on that one. So cyclic AMP production, to kind of go into more detail on that, once it's activated, the G protein coupled receptor stimulates a G protein, which in turn activates adenyl cyclase. This adenyl cyclase catalyzes the conversion of ATP to cyclic AMP. So again, that is the process of cyclic AMP production. Now, if we go into PKA activation, we're looking at high levels of cyclic AMP, which activate PKA. So again, back to the production of cyclic AMP, once you have high levels of cyclic AMP, you then activate the PKA, the protein kinase A. PKA is a tetramer composition, if you will, which is composed of two regulatory subunits and two catalytic subunits. Cyclic AMP binds to the regulatory subunits, causing a conformational change that then releases the catalytic subunits. These catalytic subunits are the active form of PKA. They cause the reaction like a catalyst. Think of a catalyst. So again, they actually cause the change to occur. Now we're going to talk a little bit about phosphorylation of target proteins. Once active, PKA phosphorylates a variety of target proteins, leading to changes in their activity, such as in the heart. These proteins include an L-type calcium channel and proteins involved in calcium handling and contraction. So again, things like troponin and then myosin binding protein C, again, causes the actual contraction to occur in the heart. All right, let's go into some cardiac effects that involve PKA and the G protein coupled receptor scenario. So the phosphorylation of these target proteins leads to their activation or inactivation, causing effects such as increased cardiac contractility or a positive inotrope, increase in heart rate, a positive chronotrope, and faster relaxation. In terms of vasoactive drugs, PKA also plays a role in vascular smooth muscle relaxation. For example, nitric oxide, which activates guanylate cyclase to produce cyclic GMP, which activates protein kinase G, PKG. PKG can then phosphorylate and activate myosin light chain phosphatase, leading to a dephosphorylation of myosin light chains, causing muscle relaxation. While this is more about PKG than PKA, I wanted to highlight how kinase enzymes are crucial in signal transduction and pathways involved in the cardiovascular system and different types of pharmacology. And remember that while these are common pathways, the specific effect can vary based on the tissue type, the specific receptor involved, and specific downstream targets of the PKA reaction. All right. So the first drug we're going to go into today is vasopressin. So vasopressin, also known as ADH or antidiuretic hormone, primarily acts on the V2 receptors in the renal collecting ducts. Activation of the G protein coupled receptors stimulates adenylate cyclase, increasing cyclic AMP. Does that sound familiar from what we went over just a few moments ago? So it then activates the PKA. So let me repeat that again. Activation of these G protein coupled receptors stimulates adenylate cyclase, increasing cyclic AMP and activating PKA. PKA phosphorylates proteins in the cell, leading to the insertion of water channels, also known as aquaporin 2, so aquaporin, into the apical membrane of the collecting ducts in the kidneys. This increases the permeability of the cells to water, which promotes water reabsorption and thus antidiuresis. Vasopressin also acts on the V1 receptor in the vascular smooth muscle cells, causing vasoconstriction. So, this is a very nice summary and a pretty concise way of how vasopressin works down to the molecular level. So, again, you're going to have a copy of this in the notes that you will be printing out, that again is listed in the show notes below. So, don't worry and don't fret if you miss some of that. My hope is that the more you hear it and the more you understand it, the easier it's going to get to have an understanding of the a mechanism of action of these drugs. All right, next we're going to go into phenylephrine, also called NEO, as for short. Often you will hear that it's like anesthesia's favorite drug because it is. We pretty much use it very, very frequently, especially in adult surgeries, not so much in pediatric surgeries, but again, there is a time and place for it.
Another daily dose of inspiration along your CRNA journey. It's finally my turn. I heard about CSPA back when it was still called ICU Dreaming About Anesthesia, back in 2019, 2020. Life got in the way and I didn't end up applying. Years down the road, I wasn't sure if I was going to apply anymore or if CRNA was still the route I wanted to take. I decided I would apply finally this year just to see what happened and jumped back into CSPA. I got into 2 dream schools here in California. I applied to 3 schools total, 2 acceptances, and will not be taking the 3rd interview. My stats are average: 3.3 GPA, 301 GRE, CCRN, leadership positions at my hospital, local Sigma Theta Tau, retook a class and did a lot of interview prep through CSPA, which is through Nurses Teach Nurses, and with CRNA friends. It is doable. Believe in your dreams, invest in yourself. Thank you, Jenny, Dr. Wilson, and team. I could not have done it without you, and thank you to this community for your supportive nature and advice. I am grateful forever. Thank you so much for sharing the story. Congratulations, you know who you are. And I'm so proud that, again, you took the chance on yourself to just apply and see what happened. And I really think this kind of strikes me as someone who maybe is unsure, right? So maybe the question of CRNA is for them because they feel so unsure about whether they'd be successful or not. And I think this is a very common experience that people don't know if it's for them because they're not certain if maybe they're cut out for it. Maybe they think they're not smart enough, or they don't have the best experience or the best leadership, or whatever it is. But I can't say this enough, that if you don't at least give yourself a chance, you're never going to be able to address potential shortcomings. And it's one of those, and I don't even call them shortcomings, but like, for example, if you never tried to make a basketball team when you were younger, would you have ever made a basketball team? No, you wouldn't. You would never have, because maybe you would try to make the basketball teams and you'd realize, oh, I'm not very good at slam dunking, or I'm not very good at dribbling, or I don't know, whatever. So quote unquote shortcomings or areas for improvement would be, you would never know what it is you need to focus on to make the basketball team. It's similar, you guys. You would never know what it is you need to improve upon to make it into CRNA school if you don't at least start the process of trying. So that's what I hope to leave you with, and I hope you guys enjoyed, and back to the show.
All right, so let's get into phenylephrine. It's a selective alpha-1 adrenergic receptor agonist. The alpha-1 receptor is a G protein coupled receptor, and its activation stimulates phospholipase C, which causes phospho, and I'm going to probably totally mispronounce this. I was actually trying to figure out how to pronounce this part of the show, and I still don't know. Phospholipidolinositol. I don't know. So these are just not words that I'm going to be able to pronounce. So let's tell you the abbreviations instead. PIP2, PIP, also called PIP, but it's some kind of phosphodilinositol 4,5 biophosphate. I have no idea. So let's just call it PIP2. Into IP3, which is another mouthful to say, but it's indosol triphosphate. And then dicycloglycerol. I hope you're enjoying trying to pronounce these, also known as DAG. All right, so let's just repeat that because I got kind of messy. The alpha-1 receptor is a G protein coupled receptor, and its activation stimulates the phospholipase C, which cleaves or essentially forms and makes PIP, IP3, and DAG. The IP3 triggers the release of calcium from the endoplasmic reticulum. Little flashback from anatomy pathophysiology in nursing school, I think. And then DAG activates the protein kinase C. So this leads to activation of myosin light chain kinase, also kind of a repeat from earlier, and increased interaction between actin and myosin, causing vasoconstriction. Phenylephrine is often used for a vasoconstrictive effects. It can also be used as a nasal decongestant due to its vasoconstrictive effects. So we typically, again, you can use something called Afran that you would, for like nasal intubations, you would always put that down the nasal passages first prior to sticking a giant tube down there, because getting nosebleed is no fun, no fun at all. So that summarizes phenylephrine. Now let's get into epinephrine and norepinephrine. I kind of combine these two because they work on very similar pathways and receptors. other than epinephrine obviously hits them all, where norepinephrine has more limitations. But hopefully you guys don't mind me kind of summarizing these together. Both of these catecholamines act on adrenergic receptors. Epinephrine acts on alpha 1, alpha 2, beta 1, beta 2, beta 3. It acts on all of them. So epi, again, is the big gun. It affects them all. And now it depends on the dose, right? The effects on these or on these adrenergic receptors depends on the dose of epinephrine given, where norepinephrine acts on alpha 1, alpha 2, and beta 1 receptors. Okay, so you were missing the beta 2 and beta 3 from the norepinephrine. Their effects vary based on which receptor subtype they act on and which tissues. And again, which receptor subtype they act on is dose dependent. So for example, activation of beta 1 receptors in the heart increases adenylyl cyclase activity, leading to increased cyclic AMP and PKA activation, enhancing cardiac contractility and heart rate, so inotropy and chronotropy. In contrast, alpha 1 receptor activation, such as in phenylephrine or NEO, which activates in the smooth muscle, causes a vasoconstriction. So again, as you can see, the pathways are very similar. It just depends on the dose and what receptor you're actually affecting based on that dose, as far as the results you get and the type of physiological effects you will see. Now we're going to go into dopamine. Dopamine can act on D1 and D5 and D2 and D3, D4 receptors, as well as beta 1, alpha 1 at high doses. At low doses, it primarily acts on D1 like receptors in the kidneys, heart, and blood vessels, causing vasodilatation. I don't know how often dopamine is actually used anymore in the ICU. I remember them using it quite often. I think Dobutamine's probably more common. I could be misspeaking, but I just know that I feel like they've moved away from dopamine. But I frequently remember doing a renal dose dopamine back in my MICU days for patients who were septic and things of that nature. Again, I don't know how often it's used for that anymore. And I think there's a lot of literature out there that doesn't state much of a clinical significance to do that type of dosing. But nonetheless, that is how D1 receptors work in the kidneys and heart and blood vessels, causing vasodilatation. At moderate doses, it acts on the beta 1 adrenergic receptors, increasing heart rate and contractility. At high doses, it acts on alpha 1 adrenergic receptors, causing the vasoconstriction. So the D1 like receptor activation stimulates adenylyl cyclase and increases cyclic AMP production, leading to PKA activation and then downstream effects. So I don't know if you guys ever noticed this recurring theme that most of these receptors activates or stimulates adenylyl cyclase, which then forms cyclic AMP, which then leads to PKA, which then causes the effect. So if you took anything from today's episode, I would write this down, because it seems it's the same pathway for cause and effect in almost all of these drugs, which is, again, when you activate that receptor, it stimulates or activates adenylyl cyclase, which then increases cyclic AMP production, leading to PKA activation and then downstream effects. So I think that's really one of the key takeaways from today's lecture, and the mechanism of action of these drugs. And then again, depending on what actual receptor they're affecting, you then know what that reaction is, whether that's beta 1, alpha 1, things of that nature. You would then have what that downstream effect actually is from this chain reaction. Okay, so adenosine is the next drug. Or I should say, adenosine primarily acts on alpha 1 receptors, which are inhibitory G protein coupled receptors. So a little bit different than what we've just covered before. This is, again, inhibitory. So again, it acts on alpha 1 receptors, but it's an inhibitory on the G protein coupled receptors. So the activation of the alpha 1 receptors opens potassium channels and inhibits calcium channels, leading to hyperpolarization of the cell and slowing the AV nodal conduction. This mechanism is why adenosine is used to manage SVT. So a little bit different type of pathway, but I wanted to at least show you a different something different than what we just kind of covered, something that actually inhibits the pathway and what the cause of the inhibitory effects are on alpha 1 receptors. And then last, we're going to cover dobutamine. So dobutamine is a synthetic catecholamine that primarily acts on beta 1 adrenergic receptors, although it also has some activity at beta 2 and alpha 1 receptors. The beta 1 adrenergic receptors are predominantly found in the heart, and their activation leads to a cascade of events. So these receptors are G protein coupled, and their stimulation activates adenylate cyclase. This enzyme converts to ATP to cyclic AMP. So again, that pathway, adenylene cyclase, converts ATP to cyclic AMP, which then turn and activates protein kinase A, so PKA. I'll say that one more time, so I think it's really important. The G protein coupled receptor stimulation activates adenylate cyclase. This enzyme converts ATP to cyclic AMP, which in turn activates PKA or protein kinase A. PKA then phosphorylates various proteins, leading to increased calcium influx into cardiac monocytes. This enhanced calcium entry leads to a stronger contractile force, a positive inotrope, and then increases the heart rate, or a positive chronotrope. So again, because we are affecting the beta 1, we are now looking at enhanced calcium entry, which then therefore enhances the inotropy and chronotropic effect of this drug. So, but the process leading to that is the same. It just, because it affected the beta 1 is why we started talking about calcium and inotropy and chronotropy. But again, the process that got them there is exactly the same as some of these other drugs, which is that the adenylate cyclase converts ATP to cyclic AMP, which in turn activates protein kinase A, PKA. So again, very important to remember that sentence right there. And then after you've memorized that sentence, you then just say, well, what receptor am I affecting? And then from there, you can kind of figure out whether it's vasoconstriction, inotropy, chronotropy, and so on. So there you go. I hope it kind of simplifies the mechanism of action of a lot of these vasoactive drugs, ICU drugs for you. So to kind of finish up and summarize dobutamine, dobutamine is often used in cases of acute heart failure or shock. It also can increase cardiac output by increasing the force of the heart muscle contractions and the rate of contractions. It does have some activity at the alpha 1 receptor, which could potentially cause vasoconstriction. However, its main effects are typically inotropic and chronotropic due to its selectivity of the beta 1 receptor. Its beta 2 activity can lead to some vasodilatation, which can lower systemic vascular resistance and thus decrease the afterload against what the heart is then pumping, further increasing cardiac output. So it does two things. It increases inotropy, and it has a slightly lowers the systemic vascular resistance, which decreases afterload, which allows that increased contractility to actually pump up or pump against a more wide open tube. I always think of veins and arteries as tubes, big tubes, little tubes. But again, the afterload again is what you're pumping against as far as that, what it's sending out the aorta and things of that nature. So definitely helps both ways. All right. So that again summarizes the drugs that we're going to cover today. And if you do the printout, I also have amiodarone, atropine, and lidocaine on the handout as well, just as additional drugs that I feel like you should know that you may commonly see in the ICU. That really would be fair game in this CRNA interview. So I hope you guys enjoyed this summary. I know these are complex episodes, but I'm hoping I helped simplify it and make it seem less scary to you. That again, it really comes down to a relatively simple pathway. And if you remember again, that pathway as far as the basic pathway that leads to the downstream effects, then the only thing you really have to then ask yourself is what receptor are we affecting? And then from there, you can kind of gather what the effects are going to be. All right. Well, thank you guys so very much. And again, remember to grab your notes and the show notes below. And I will see you guys next week. All right. Take care. Bye-bye. Hey, future CRNA, as always, I appreciate you and your loyalty. Thank you so very much for tuning in this week. I'd love to hear from you, so screenshot this episode and share it to your IG stories with your biggest takeaway. Don't forget to tag me at CRNA School Prep Academy so I can personally thank you. Be sure to head over to CRNASchoolPrepAcademy.com to check out our blog and gather free resources to help you along your CRNA journey. Stay strong, and I'll see you next week.